Here are my disclosures, and off we go. So what's the big problem with CTO? So 40% of patients treated with PAD have chronic total occlusions of the SFA. And really dealing with these issues and tackling these cases, there's obviously the risk of perforation, dissection, embolization, increased radiation, and contrast exposure. And then, it's really the most common reason for surgical bypass. You've heard many people argue that we should have an endovascular first approach, and obviously if you can't cross the lesion, then you can't treat it. You cannot have technical success without that. And so again, that leads to an open bypass, which again, the right hands is not a bad thing and is a durable procedure for the patient. So here's our algorithm overview, and again, this is put together and presented at TCT in 2018. And it breaks down, whether or not you're going, whether you're going antegrade with wiring versus going retrograde, and then your goals of whether or not you're going to go true lumen versus going within the subintimal space, which I think, in my opinion, again with my experience, is something that you have to decide very early on in the procedure, and it certainly can save time. Here's a more simplified algorithm, and we'll start on the left side. Again, it's wire-based, where you get into the subintimal space. You encounter your distal cap and either try and get into it and back into the true lumen, normal vessel, or if you're unable to do so, then the use of a reentry device is always an option. Though I will say in my practice, we don't use reentry devices at all. I think I probably used 2 or 3 over my 7 years. Before you can even start thinking about how you're going to tackle these lesions, Dr. Mustafa and his team actually helped to come up with a classification of the CTO caps. And again, this really dictates how you're going to approach a patient and which way you should go with your wires. The important point being that whenever you have concavity of the cap, you can likely expect that wire to try and find its way into the true lumen, even if it's heavily calcified. Whereas if you're coming from above and the cap is more convex, then your wire will tend to slide along into the subintimal space. And so it's just important, again, in the planning portion, when you see these lesions on duplex beforehand or on the initial arteriogram, deciding what kind of cap you have, again, dictates what you should do and whether or not you're going to need retrograde, or likely need retrograde access or a reentry device in order to be successfully get into the true lumen and connect normal vessel to normal vessel. So when you're talking about wires and catheters, again, some of the key attributes to think about is the tip stiffness, as the force required to buckle the tip, and that impacts the crossing ability in challenging lesions. And as you can see, the case that Andre is doing right now, again, that's the idea, is being able to get the wire to buckle and giving you a little bit of rail to get through the lesion. Finally, the torque response that enhances the ability of the guide wire to navigate and select side branches as needed. You need rail support, again, which is a function of the stiffness of the guide wire itself, and that enhances the pushability and device support of the guide wire, but may also reduce the ease of navigation of the wire itself. Then finally, lubricity is an important characteristic to think about, and may decrease the frictional force and enhance the ability to cross a lesion. This can often be overcome by trying to predilate the area that your wire is going through. But again, that lubricity is an important characteristic. There's a multitude of wires that can be used, and I think the biggest advice, if I were to give that to anyone, is you pick the wires that work best for you. You have a set of 4 or 5 that really work well for you, and use those and learn how to make those dance. Again, there's a plethora of options available. For my cases, again, I like the Command and the V18 system by both Abbott and Boston. And then not listed on here is a glide wire Advantage, is a good working wire with a good amount of stiffness, but you still have the hydrophilic tip to be able to work with. And then finally, for the crossage of CTOs and for wire escalation when unable to do so, you can start with the 014 Miracle Brothers and then elevate to or escalate to a Stato 20 or a Stato 30. Again, with the idea of getting through the cap and trying to stay within the true lumen, which again, my mentor, Dr. Mustafa, has really kind of perfected with the use of extravascular ultrasound. And most people don't have that advantage. So the support catheters are really, again, it's kind of the same idea. There's a wide array of support catheters that help make these cases easier and make them possible. Again, my preference is the Quick Cross system, and really my best workhorse catheter is the Navicross, which has a braided backbone. Again, allows you to has significant support, and also has the taper tip, which allows it to be used with even an 018 wire without it hanging up along the edges. So again, one of the other important points and that I think is in this key to being able to tackle these cases is ultrasound guided access. I know seeing the cases in Europe throws us off a little bit, and again, that's a part of the training, is being able to access under fluoroscopy. We try to stay away from that because of radiation exposure, and then again, with ultrasound guidance, you can essentially access any vessel that we use in the periphery, from radial to pedal access. Again, it's an overlooked skill set. I think you have to be a CLI expert to be able to do so, and it's safe and effective in the right hands. And Bryan, this is for you. I want to emphasize that for people that do pedal access, it's not something to be taken lightly, especially someone that has claudication, let's say Rutherford class 3, difficulty walking. You know, I've certainly had instances in patients being transferred to me that end up losing a foot because someone decided to do pedal access that didn't have experience. But again, in the right hands, it's an absolute game changer and can change the technical success of crossing a lesion from probably 60 to 70% all the way up to 90, 95+%. Again, that's without using a reentry device. I like to use IVUS. I know a lot of people talk about it taking more time. Use IVUS from retrograde with single wire access or single wire control. When you floss the patient, I like to take the IVUS catheter back and forth to see exactly where I'm in the vessel and again help guide my therapy. And then just finally, some of the key tricks. Again, no reentry devices. I just don't use them, don't need them. Ultrasound guided retrograde access really takes care of that. And then getting the wire to double over. Now,